Sakshi.
Good afternoon, everyone. I'll be presenting on anterior uveitis and ankylosing spondylitis, inflammation at the core. How do you forward it? Uveitis is a state of ocular inflammation due to various immunological or non-immune causes, leading to varied complications, cataract being one of the most common. It may be mainly due to uncontrolled or sustained inflammation, but also by prolonged dose of hydrosteroids. The interplay between uveitis and cataract formation can result in blurred vision, increased intraocular pressure, and difficulties in surgical management, making timely intervention and precise treatment crucial. Case details. A 35-year-old male walked to our OPD with cautious gait pattern with multiple joint deformity with chief complaints of intermittent redness, watering and pain in left eye since 1 year and diminution of vision in left eye since 6 months. The intermittent episodes of redness, pain and watering subsided after temporary treatment with topical drops which were not known by the patient. And the diminution of vision was gradual in onset and progressively increasing. In right eye, patient has a history of loss of vision since childhood after trauma with a wooden stick, and the eye was thicycle. There was no history of colored halos, floaters, sticky discharge surgery or any spectacle use, but he had a history of joint pain in large joints of upper and lower limb and backache since 10 to 15 years. He had a history of TB in 2005, for which he took medication for 6 months, and history of poliomyelitis since childhood. There was no history of any systemic illness or any ongoing drugs. The visual acuity in right eye was PL negative because of thicycle. In left eye, it was hand movement close to face and PLPR accurate in all quadrants. Intraocular pressure was soft in right eye and 42 in left eye. On slit lamp examination, left eye showed fluid normal, there was circumcorneal congestion, there was vascularization superiorly from 11 to 3 o'clock, there were old fine KPs in inferior quadrant, the AC was shallow with peripheral anterior synechiae, there was no cells and flare, and there was iris bombay, it had a seclusive and occlusive pupillae with irregular 3 mm pupil not reacting to light, and there were early cataractous changes in the lens. And the fundus examination showed dull red glow on DDO and 90D examination. So we made a provisional diagnosis of left eye chronic uveitis with secondary glaucoma and complicated cataract, probably due to rheumatoid arthritis, which was suspected. On investigation, ESR was high, CRP-RF factor ASO was negative, and on X-ray, cervical and spine showed bamboo spine on the dorsolumbar vertebra, suggesting ankylosing spondylitis. And hence we did a HLA-B27, which came out to be positive. The B-scan showed right eye phthisis and left eye was within normal limits in the posterior segment. So the target of treatment was for inflammation control, IOP control, cataract extraction, and vision rehabilitation. On medical treatment, we gave anti-glaucoma drugs and topical antibiotics 15 days before surgery, oral steroids and topical steroids 1 week prior to surgery, and we also did a NDI laser iridotomy for better IOP control. We then went to surgical management, which included manual SICS with membrane peeling, anterior and posterior synecholysis, cataract extraction, and hydrophobic IOL implantation in the back. So post-operative, IOP was well controlled at 40 nm Fg after 1 month without any medication. There was inflammation control with nepafinac and topical corticosteroids, which were discontinued 2 months after surgery, and systemic steroid continued tapering doses as per the rheumatologist's opinion. One of the major successes of the surgery was achieved in terms of good visual rehabilitation of BCVS 618 after 1 month of follow-up, and there was no CME or any other abnormality on OCT. So uniqueness, it was a rare case of chronic uveitis with secondary glaucoma and complicated cataract in a one-eyed patient who presented very late when the vision was PLPR due to associated pain. The patient had multiple joints with bamboo spine on joint pain with bamboo spine on X-rays and HLA-B27 positive, suggesting ankylosing spondylitis. So clinical implication include that complicated cataracts with chronic uveitis difficult to deal with because of number of complications, and post-operative monitoring should also be done to look for complications such as CME or posterior capsular opacification. So the take-home message is patients with poor vision and recurrent symptoms, especially one-eyed, and those predisposed to recurrent chronic inflammation must be paid special attention for better visual rehabilitation and prognosis to improve their quality of life. Thorough systemic evaluation is necessary to know the systemic cause of uveitis and to treat the cause and seek rheumatologist opinion before it is too late. Also, post-op care and follow-up in uveitis is equally important as diagnosis and treatment of the disease. Thank you.
Sakshi, what was the gonoscopy finding?
So there was 360-degree synechiae present and peripheral anterior synechiae.
Would it get controlled with the PI or would it require trap?
It would, first sir, we tried for the PI, but it was uncontrolled, like the IOP was reduced.
The pressure was 14 millimeters without any medication after cataract.
Yeah, before any,
so
without any medication.
It would open up, or you require trap long term or anti-glaucoma medication long term?
So, sir, firstly, as it was 42, we tried first anti-glaucoma medications. Like we started only on 2 or 3 drugs, but there was no improvement. There was the
I'm
IOP
just saying
decreased.
patient is now better. Do you think it will require TRAB or anti-glaucoma medication long term? Because when you have peripheral, they will keep closing. The inflammation is
Yeah.
not going to die down. And do you think
Patient
in
may
a chronic
require a
patient,
TAB,
the
sir.
flare will ever disappear?
Yes, sir.
So again, I want to highlight that steroids for 6 weeks is not the treatment for chronic uveitis. The patient needs to be on biologics or antimetabolites for life. Is
Yes,
one-eyed. Again, next uveitis will be unsparing. The patient will go blind with glaucoma over a period of time. So do not think that perioperative steroid is just the job. So
Right.
you didn't start immunosuppression. I am surprised the rheumatologist didn't advise
So actually, the
immunosuppression.
patient was not even affording for
So
immunosuppressant.
the
So
immunosuppression is the
Very
cheapest.
cheap.
Methotrexate is very cheap.
Very
15
cheap.
rupees.
I
patient
think-
was lost to follow
I
up.
I
think-
also.
understand, but if you're presenting a case, you should have written that that is the
Yeah.
method of treatment.
So
no?
ma'am, I
Mass
think
is-
one of the reasons I think that the IOP was 14 millimeters after surgery was that it was a recent, maybe sir, it was a recent onset, because once once you know the iris it sticks to the angle, a gonius synechia or a peripheral anterior synechia becomes permanent within 48 to 72 hours, rather even earlier in a case when it's in the case of uveitis. So although it seems a little improbable to digest that the IOP became 14, sir. 14, I mean,
Very difficult, you know, once
but
synechia
even if
forms.
it did, so I mean that one reason could be that the angle has opened up and it was the recent onset iris Bombay. Second is that there is now a ciliary body shutdown.
Ciliary body shut down.
So these are two problems. I mean, I want to.
So superior incision SICS, you're looking for a trap later. So don't make a superior incision. Trap would be required. Your gonioscopy says that it's going to close. Patient requires long-term immunosuppression. So these two things one has to remember. Thank you.
Thank you, sir.